I want to thank the organizers for inviting me today to talk about study designs to benefit older adults using archived clinical trial data. My name is Dawn Hershman. I'm a American Cancer Society Professor of Medicine and Epidemiology at Columbia University Medical Center. When we think about strategies to inform decision making, we often break clinical trial designs into two categories: randomized controlled trials and observational studies to help us inform decision making. Randomized clinical trials have the advantage of allowing us to select a population of interest, enroll them based on strict eligibility criteria, identify eligible subjects, and randomly assign them to intervention A or B, and looking at those effects on outcomes. Observational studies, however, look at large cohorts of patients, whether they're a part of cohort studies or more recently from observational studies with linked data, where patients are determined to get intervention A or B based on preferences. And we use patient factors, provider factors, and system factors, as well as other factors to try to control for confounding to help us understand the differences in real world populations, what those differences may be between intervention A and intervention B. So randomized clinical trials and observational studies have advantages and disadvantages. Randomized clinical trials have the advantage of prospective data collection, randomized treatment assignment, and prognostic data that are collected at baseline, but they have the disadvantage of including selected patient populations and strict eligibility criteria that can decrease generalizability. They have limited baseline data that's often collected on the trials and limited long-term follow-up, and they can take a long time to do. Observational data has the advantage of having large numbers, real-world data collection in practices, long follow-up, and lower cost. But the problem is selection bias. The associations that are found are often can't be determined to be causal. We have unknown patient preferences, lack of detailed information on many other components of their treatment and prognostic factors, and often no data on the severity of any of the diagnoses that are obtained. So one option is to try to do observational studies from randomized clinical trials. That can have the benefit of randomizing patients based on treatment assignment to limit bias, collecting prognostic factors that are often collected in randomized trials, having uniform treatment, and prospective follow-up for things like progression-free survival and disease-free survival, which can be difficult to obtain from observational data. And especially if you use large clinical trial networks, you can have increased generalizability because patients are enrolled in multi-center studies all throughout the country from both community and academic sites. The other advantage is that you can use these large trials to look at special populations, such as the elderly, or by race, or by insurance status, by combining results of multiple different clinical trials, so you can have larger numbers. And another thing you can do is try to link them to claims data, such as Medicare claims, where that can allow you to collect data that you might not necessarily collect in a prospective trial, such as long-term follow-up data, comorbidity data based on claims, new diagnoses or procedures that may not be captured in randomized trials, and sometimes health utilization and cost data. So that's exactly what we have done in one of the cooperative groups, SWOG, where we've linked to patients with large, through our large clinical trial database of patients enrolled in clinical trials to their Medicare claims. And Medicare is obviously only in patients over the age of 65. So it gives us some understanding of elderly patients. And so I'm going to give you some examples of different things we've done to get some idea about outcomes in elderly patients on clinical trials through this linkage between Medicare data and SWOG data. So first, I'm going to tell you about a study of intermittent versus continuous androgen deprivation therapy for patients with metastatic prostate cancer that were enrolled in SWOG 9346. One of the issues with this trial was that the overall study was difficult to interpret at the end. There was no real clear advantage of intermittent over continuous. But one of the thoughts for this trial was that intermittent therapy may result in decreased toxicities over time. We were able to look at elderly patients enrolled in this trial because the vast majority of patients were over the age of 65. And we looked at a variety of different outcomes. We found really no apparent reduction in many of the long-term outcomes, such as osteoporosis and fracture, endocrine or cognitive events. But one of the things we were able to show was that patients that were enrolled in intermittent therapy had a higher rate of ischemic events and ischemic heart disease. So this was an unexpected finding in the elderly, but it gave us insights into some of the implications that we need to be cautious with this intermittent therapy in this elderly patient population. Another thing we did was look at elderly patients enrolled in the prostate cancer prevention trial, where patients were randomized to finasteride versus placebo. One of the concerns with this trial was that maybe there may be some difference in the outcomes over a longer period of time that were followed on the clinical trial. We were able to link patients to their Medicare claims and follow them for more time, up to 16 years. And we found that the benefits of finasteride that were seen in terms of prevention continued over this longer period of time, with a statistically significant reduction in BPH-related symptoms to those patients that were enrolled in the finasteride group. But we're also able to show that patients that were enrolled in the finasteride group had higher rates of depression, but did not have higher rates of diabetes, ischemic heart disease, thrombotic events, or sexual dysfunction, which I think was reassuring. So the implications were really that there was no need to worry about long-term non-cancer consequences of patients enrolled in the finasteride arm. We've also used this data to give us a better understanding of toxicity and toxicity development in elderly patients enrolled in clinical trials. By merging clinical trial data from patients enrolled in multiple trials. And this is results of a study where we included data from 23 different studies, 1,400 patients over the age of 65, to look at neuropathy rates. And by doing that, it gives us insights into elderly patients and what their risks are. And we found that elderly patients with diabetes specifically had a twofold higher risk of the development of neuropathy when they were on a clinical trial of an agent that was known to result in neuropathy, such as taxane. We've been able to use this data to give us a sense of comorbidities and risk of cardiovascular disease. This is results of patients enrolled in prospective studies looking at their baseline comorbidities such as hypertension, diabetes, coronary artery disease. Often these things aren't captured on clinical trials. This is breast cancer data that suggests that these comorbidities are associated with an increased risk of cardiovascular events, both during and after enrollment to clinical trials. We're also able to look at patient-reported data, specifically in the elderly, and we looked at clinical trials that included patient-reported outcomes and patients specifically that reported severe fatigue at baseline at the time of enrollment. These trials included about half the patients were over 70, and about half patients had significant fatigue at baseline. But what was interesting in these studies is that patients that reported higher baseline significant fatigue had worse survival outcomes, both for lung cancer and prostate cancer, which gives us insights into how patient-reported outcomes can be used both as an inclusion criteria, but also in the study designs. I also wanted to mention that clinical trial data, merge data can be used to inform policy that can affect elderly participation in clinical trials. And data from SWOG in this trial, looking at comparison of the U.S. patient population versus SWOG clinical trial enrollment, showed substantial under enrollment of patients over the age of 65 compared to incidence. This is a landmark paper that was published in 1999 and really led to increased understanding of enrollment to clinical trials and resulted in policy changes to Medicare reimbursement of clinical trials. And those policy changes had an impact in terms of increasing the likelihood of patients being enrolled in clinical trials. And you can see before and after, patients over the age of 65 had an increase in enrollment, but specifically limited to patients that have both Medicare and private insurance. Similar results recently have been used to inform policy, showing issues related to insurance affecting clinical trial results. Patients with these from 2 trials using SWOG data have shown that patients with less insurance, patients specifically with Medicaid or no insurance, are less likely to be enrolled in clinical trials. And actually, patients with Medicaid don't have the same benefits when the treatment is known to be beneficial on the clinical trial. Results from these trials were really used by ASCO and other organizations to help advocate for increased funding for patients with Medicaid so that their clinical trials costs will be covered. And that is a very direct way we can try to increase clinical trial in accrual to on trials. So there are many opportunities using these large linked databases. Many important questions can be answered from clinical trial data to help us understand diffusion and efficacy of new treatments in the community. Better understanding of barriers to enrollment is vital to increase access and allow us to interpret clinical trial results for all patient populations. Innovative big data type approaches are necessary to address many of these questions, and easier and creative ways of making linkages can help us understand and answer new questions in the future. Thank you very much, and I'm open for any questions.